Members of my society, myself Dr. Archana Khare, welcome you for the today's CME on the behalf of my team. Cervical cancer, as we all aware, is the most common malignancy that we come across in India. What makes it important is the fact that it is the most preventable and treatable form of cancer. In November 2020, the WHO formally launched the global strategy to accelerate the elimination of cervical cancer. The fact that International Agency for Research on Cancer has also designated January as a dedicated cervical cancer awareness month is probably enough to vouch the gravity of this problem. Before any further delay, let us embark upon today's informative and interactive CME. I request our President Dr. Anjali Jamma ma'am, please welcome the August gathering.
Good evening and welcome to you. I take this privilege to welcome our esteemed speakers, chairpersons, teachers, seniors, and my dear friends. All of us are well aware that cervical cancer is the fourth most common cancer in women. Majority of cervical cancer cases are linked to infection with high-risk human papilloma viruses, an extremely common virus transmitted through sexual contact. Although most infections resolve spontaneously, persistent infection can cause cervical cancer. Effective primary and secondary prevention approaches like screening and treating precancerous lesions will prevent most cervical cancer cases. When diagnosed, cervical cancer is one of the most successfully treatable forms of cancer as long as detected early and managed effectively. Like stitch in time saves 9. To improve our skills, we have a esteemed faculty, Dr. Mittal, Dr. Doshi, Dr. Meru, and Dr. Nikhil Parvate, sir. I welcome you all and thank you for attending CME. Thank you. Over to you, Archana.
Thank you, ma'am. Let's start today's CME. I request Dr. Runda Chaudhary ma'am and Dr. Praveen Khare to chair the session. Dr. Runda Chaudhary ma'am is beloved teacher, great academician, HOD of Kumbhari Medical College, very student friendly person. Welcome you ma'am. Dr. Praveen Khare is director of Tapasya Nursing Home, laparoscopic surgeon of Solapur, Usmanabad and Latur district. He performed more than 25,000 tubectomies in last 6 years. He is a joint secretary of Cancer Society, completed his fellowship in oncogynecology from Tata Hospital, recently nominated from Maharashtra for performing highest number of tubectomies. Over to you, sir and ma'am.
Good evening to one and all, respected seniors, my colleagues, students. We see all the people around us in the society becoming more conscious about health, food conscious, exercise conscious, weight conscious, everything. But it's too early to comment whether it has got an impact on the preventive oncology as far as it is concerned. We have to depend on secondary preventive measures. All over the lifetime, the woman, we have got vaccines as far as secondary preventions are concerned. Better cellular yield techniques, we should more adapt to that. Then all imaging modalities, TVS, colonoscopies, mammographies. Let us we have got a panel of speakers talking on these secondary preventive measures. Over to you, sir.
Welcome all. Today's our first speaker is Dr. Sarita Mittal madam. She is a HOD of Pathkind and she is MBBS, DNB, Pathology, MNMS, and area of interest expertise are histopathology, cytology, immunohistochemistry, bone marrow aspiration and biopsies, making standard operating procedure for test and development of quality assurance programs. Over to you, madam. Dr. Sarita Mittal, madam. She will be speaking on cancer screening, liquid-based cytology.
Good evening everyone. Today I'll be talking about cervical cancer and role of LBC in diagnosing these cancers. So if we talk about Indian scenario, the disease burden is very high. Cervical cancer is the second most common cancer in Indian females, and more than 120,000 cases occur annually in India, and approximately 7,000 deaths occur in India. And if we compare total number of cases, then 1/4 of the total number of cases and 1/4 of the total number of deaths are reported from India. It's very saddening to say that 1 out of every 4 women who dies of cervical cancer is an Indian. So, but the cervical cancer, we all know, is a preventable cause of cancer. So we don't really need to cure the cancer, we can only prevent by various methods. So if we talk about the etiology of cervical cancer, the most common cause in more than 99% of the cases is human papilloma virus. And human papilloma virus is of 100 different types. They are divided into 2 categories. One is the low risk group and other is the high risk type of group. Low risk are HPV 6 and 11, and they are responsible for genital warts, etc. But high risk group, which constitutes HPV 16, 18, 31, 33, 45, 52 and 58, they are responsible for more than 75% of the cervical cancers and other cancers like vaginal, vulvar cancer, and at times in oral cancers also caused by HPV. So there are other risk factors also associated, and if a patient has HPV and there are other risk factors, the chances of developing cervical cancer become more. The other risk factors are multiple sexual partners, if the patient or the person is on birth control pills, with the smoking, and if the immune response is weakened, and if there is any other associated sexually transmitted disease. So these are the risk factors. If we talk about the natural history of cervical cancer or the natural course of the cervical cancer, the course is very slow and slowly progressive. It takes almost 10 years for a normal lady to develop cervical cancer after HPV exposure. So once the lady is infected with HPV, there are chances, in 90% of the cases, the infections are cleared within 2 years. But if there is any persistence of infection because of any reason, maybe because of the weakened immune response or any reason, the persistent infection can lead to various pre-invasive lesions, which are divided into SCUS, LCIL, HCIL, AGUS, etc. Then these lesions with other risk factor can lead to development of frank carcinoma. So the duration is approximately 10 years, and because of this long duration and slow course and various pre-invasive lesions, it has become the preventable cancer. So the pre-malignant stages can be detected by various tests like Pap screen. So with the investigations, if we diagnose the disease at an early stage or at a pre-invasive stage, the prognosis become better, and there is reduction in cancer related deaths also. In less number of cases, radical treatment is required, so the cost of treatment is also less, and with the negative Pap smear is very reassuring for the patients also. So now the cervical cancer can be detected by various investigations. The most common investigation which is done is Pap smear. The Pap smear is conventional Pap smear or liquid-based cytology, and there is HPV testing also. Nowadays, it is recommended to go in for co-testing for LBC as well as HPV testing, but HPV testing alone can also be done to detect these pre-invasive lesions. So what is the best time to take Pap smear? The Pap smear, it is best to take in the middle of the cycle, from 9th day of the cycle to 20th day of the cycle. It should not be done during the menstrual phase. The other instruction which we need to give to the patients, there should not be any tampon should not be used, no birth control foam or cream jelly or any medication should be used if we want to take the pap smear. So in conventional pap which was used before, we need to scrape the cells from the ectocervix as well as from the endocervix with various spatulas and spread it on the smear and see it under the microscope. This was the conventional method of taking pap smear. So these are the various spatulas which were used. There is cervical broom also, cervical brush. But with the conventional pap smear, most of the cells are discarded with the spatula or with the brush. So the representative cells are not transferred to the smear. So there is a high false negative rate in case of conventional pap smear. So the high false negativity is because of the improper sampling, because the entire specimen is not transferred to the slide, and there are various obscuring factors like blood, mucus, etc. on the slide. Now, if we spread the cells directly on the slide, there are thick and thin areas. The slide is from one edge of the slide to the other edge, so it's very difficult to screen the slides. And there are various drying artifacts, nuclear molding, etc. and feathering. So all these lead to false negativity in cases of conventional pap smear. To overcome these shortcomings of the conventional pap smear, liquid-based cytology is preferred. In liquid-based cytology, we take the cells in a fixative, which is generally a ethanol or methanol-based fixative. Then these are centrifuged, homogenized, and a palette is made on the slide, which is a monolayered sheet. So the cells are not one above the other, they are singly spread over the smear. So the shortfalls of the conventional smears can be overcome by doing liquid-based cytology. Overall, the yield of the cells is more, the entire specimen is represented on the slide, and we can do the liquid-based cytology kit can be used for other testing also. This is the other advantage, like HPV testing can be done on the same sample. So there are two methods to collect LBC. One is the SurePath method, which is done in our lab at Pathkind. The other one is thin prep method. There is mild difference between the two. In SurePath, the ethanol is used, while in thin prep, methanol is used, and the procedure is also different. In SurePath, centrifugation method is used, and in thin prep, filtration method is done. But FDA has approved SurePath method over the. This is the SurePath vial which is available all across. I'll show you one video to how to collect the. Just.
At BD, accurate definitive results begin with sample collection. The BD SurePath collection vial is a simple yet vital part of the screening process, making sample collection easy and effective, giving you greater confidence in your patient's results. The Rover cervix brush is designed to deliver rich cell yield by sweeping the ectocervix and reaching well beyond the transformation zone into the cervical canal. The bristles of the brush are flat on one side and rounded on the other to provide a gentle scraping edge when rotated clockwise. Because the bristles are flexible and conform to the patient's cervix, you can get a good sample of the mucosal surface without damage. This device can be used with most patient populations, including pre- and postmenopausal women. Collecting a sample for a BD SurePath liquid-based pap test using the Rover cervix brush is easy. Insert the extended bristles on the tip of the Rover cervix brush into the endocervical canal. The extended bristles will stiffen and penetrate the cervical os. Gently push the brush into the cervix until the lateral brush bristles splay out over the ectocervix. Maintain gentle pressure and rotate the brush 5 times clockwise by rolling the shaft between your thumb and forefinger. The flat edge of the brush gently scrapes the cells from the cervix. Rotating the brush 5 times ensures the brush has collected a good endocervical sample. Once the sample has been collected, send the entire brush head to the lab using the new BD SurePath collection vial. Hold the collection vial firmly down on a flat surface and then insert the brush head into the larger opening. Rotate the brush 1/4 turn and then use the inner edge of the insert to pull off the brush head right into the vial. Be sure to put the brush into the larger opening in the vial insert. Do not drop the brush head into the smaller opening. This opening is for lab instrumentation.
So this is the way the sample is collected. So now, what are the advantages of LBC over the conventional method? As I have already told that more representative cervical sampling is done. All the cells are transferred to the glass slide, so we can visualize the entire sample. There are fewer artifacts like the mucus, blood, everything is rinsed off. Then obscuring factors are not there, the cells are in monolayered sheets, and the PAPS liquid-based material can be used for other testing like HPV DNA testing. So this is the conventional pap smear and LBC. In conventional smear, we can see there are thick and thin areas, the material is spread from one edge to other edge, while in case of the LBC, it's a beautiful small button with monolayered sheets of cells. So this is the photomicrograph of one side is LBC, in which we can easily appreciate the intermediate and superficial squamous cell, while the other smear is of conventional, where there are artifacts like there are inflammatory cells, there is some mucus, there is some overlapping. So LBC, there is better morphology is better preserved. So after the smear is taken, the reporting is done according to the Bethesda system. Now there are some guidelines that who are the patients should be screened for this pap smearing. Under the age of 21, the screening is not recommended, but now the guidelines have changed. In 2020, they have changed the guidelines. Now the age is 24 years. Now till the age of 24 years, no screening is advised. After the age of 24 to 29, initially it was thought that only pap smear is recommended, and if there is any abnormality, then we can go in for HPV and reflex testing. But now, at the age of 24 to 29, they are recommended that PAPs as well as HPV testing should be done. So there should be a co-testing, or only HPV is also done in some cases. At the age of 30 to 65, it is advisable to go in for co-testing only at the interval of 5 years, or if we are doing only cytology, then at the interval of 3 years. After the age of 65, it is advisable to stop the screening. There should be at least 3 PAP tests should be negative, or 2 co-testing should be negative before stopping the screening after the age of 65 years. So now there are few questions which are frequently asked. So a 20-year-old girl, G1, P1, present for contraception, what would be the advice for cervical cancer screening? There should be no screening, no PAP test, but at the age of 21, HPV testing, or HPV test as well as PAP test. So, as I have already told, till the age of 24, no screening is advised. So, the consensus said that no screening is advised till the age of 24 years. Second case is 21-year-old lady comes for her first cervical cancer screening. She is sexually active, assuming the first PAP is negative. Now, what is the next screening schedule for this lady? So, the lady is 21 years. sexually active, first is negative. So, till the age of 24, no screening is advised. If the lady is beyond 24 till 29, then nowadays co-testing is advised or only HPV DNA testing is advised. Third case is 31-year lady for PAP testing. So, which is the preferred method? So, co-testing is advised for 31 to 65 years of age according to consensus. After the age of 65 years, we can stop the screening if there is adequate negative screening. Adequate negative screening means if there are 3 consecutive negative cytology results or 2 consecutive negative co-tests. So, we can stop the screening after the age of 65 years. Now, there is a case if a lady is PAP negative but HPV is positive. Now, we have to see which type of HPV is positive. If 16, 11 or low risk group, nothing is to be done. While if in such cases, the testing has to be more frequent since the HPV is positive. We don't know which HPV is positive, but it has to be more frequent. So, a co-testing is advised after interval of 1 year in case of HPV positive patients. If after 1 year the co-testing is again done, and if HPV is again positive, we can again repeat after 1 year. But if on genotyping it is HPV 16 or 18, then we have to go in for colposcopy only. The second is, there are some cases in which the patient had hysterectomy. So, what is the requirement of cervical screening in such patients? So, even in cases of hysterectomy, the decision is based on whether the initial hysterectomy was done for some cervical abnormality or something else. If the patient had any type of SIN1, SIN2, HSIL, LSIL, then the screening has to be continued for 20 years. While if there is nothing before, then the screening has to be done according to the age protocol, because even in us, if his uterus is removed, few of the cells are present in the upper part of the vagina. So, screening has to be continued. Then there are certain scenarios in which the frequency of the screening is more. Those are the cases in which there is some immunodeficiency, or the patient is exposed to diethylstilbestrol, or there is a history of cervical cancer prior. So, in these cases, the screening has to be more frequent than the normal. Now, there are few cases in which there is HPV vaccination already done. In those cases also, the routine age recommended screening has to be followed. After the screening, now the results can be variable. So, in most of the cases, like 96% of the cases are negative, there is no abnormality detected, while the frequency of LSIL is 0.97%, high-grade SIL and atypical glandular cells is 21%, atypical squamous cell in which the higher grade lesion cannot be excluded is 0.17, and frank cervical cancer is 4.5 per 1 lakh patients. So, these are the photomicrograph. The first one is SOGS, in which there is mild nucleomegaly, but the nucleus is not that enlarged or hyperchromatic. The second one is HSIL, LSIL, in which there are quillocytes. I think pointer is, it's not working. Yeah, these are the quillocytes in which there is perinuclear clearing, there is resinoid nuclear membrane. So, this is the case of LSIL. Third one is HSIL, in which the nucleus is enlarged, the NC ratio is very high, it is irregular and hyperchromatic. And this is frank squamous cell carcinoma because of this tumor diathesis and these tadpole-like cells. So, these are the findings which we can get in cases of screening. So, what is to be done? If we are getting SOGS, then nothing is to be done, only the patient has to be followed up, and the screening has to be more frequent, that is at an interval of 1 year. Even at the interval of 1 year, if the screening is negative or if there is no HPV detected, then we can follow the routine guidelines. While if HPV is positive and for 16 or 18, then directly we have to go in for colposcopy and ultimately the biopsy. Same with the LCIL, the patient has to be followed up only, nothing is to be done, but if we, at any time the patient is found to have HPV 16 or 18, then again we need to go in for colposcopy, similarly with HCIL. So, in pre-invasive lesion like HCIL, like LCIL and SCUS, we have to do more frequent screening, nothing is to be done. While in cases of HCIL, the screening is to be done more frequently as well as colposcopy is advised immediately. So these are the biopsy findings. Once the colposcopy is done and biopsy is taken, so these are the findings which we can see. For this one is the LCL. Again the coilocytes are visible. There is perinuclear clearing and resinoid nuclear membrane. Here the changes are throughout the thickness of the lining. So this is HCL, and here we can see few cells in the deeper part. So it's a early invasive squamous cell carcinoma. We can get any of these. So once the diagnosis is confirmed by doing colposcopy and biopsy, then we need to treat the patient. So there are various methods available for the treatment of the patient. Now there is one other entity is known as AGUS, atypical glandular cells of undetermined significance. Now the glandular cell in the pap smear can come from the cervix, endocervical cells, or from the endometrium. Or the squamous cell has become so atypical that they appear glandular in nature. So in all these cases, if the glandular cells are present in the pap smear and they are atypical, we have to do endocervical sampling also. If on endocervical sampling there is some abnormality, then we need to do conization. And after conization, if the carcinoma or pre-invasive lesion is confirmed, if there is carcinoma, we have to do Verdheim's hysterectomy only. And if there is pre-invasive like adenocarcinoma in situ, then simple hysterectomy will do. So the treatment has to be decided on the basis of the result of biopsy. So in the end, I would like to say that with the pre-invasive tests available, screening tests available, we can detect most of the abnormalities at a very early stage. And in low-grade cases, we just need to follow up the patient at more regular intervals. Higher-grade lesions can be treated, abnormal cells can be removed. LBC is always preferred over conventional PAP, and co-testing is advisable.
Any question from audience?
Madam, how much it is useful as far as mass screening is concerned, or this liquid-based cytology?
Mass screening is not at all done in India, but it is advisable to do.
Or
Since we can
it
pick
should
up
be
the
restricted to all VIA positive or VILI positive, like that.
Pardon?
It should be restricted to those who are acetovyte positive, like paramedicals going.
acetovyte positive also, but we can screening can be done if even if there is no abnormality detected.
Yeah, of course.
Acetovyte is some abnormality is there, but screening has to be done in entirely normal
All-
population.
okay. Nicely explained the importance of this downstaging and liquid-based cytology. So, thank you, madam.
Thank you, ma'am. I request our chairperson and Dr. Anjali Jamma, ma'am, please felicitate Dr. Sarita Mittal.
Our next speaker is Dr. Vaibhav Meru sir. He will be talking on imaging in CA cervix. He is a consultant radiologist, presented many papers and posters, director at Prism Diagnostic Center, MRI consultant at SP Institute of Neurosciences. Over to you, sir.
माउस आहे काय माउसचा पॉइंटर हाच की हां करेक्ट हे असं ना हां येस आणि खाली वर करायचं असेल तर पुढे या मग ओके ओके माउस टू ओके
Good evening, everyone. At the outset, I would like to thank Dr. Anjali Jamma ma'am, Dr. Monica, and other office bearers of the SOGS for giving me this opportunity to speak on the imaging in the carcinoma of the cervix. We'll cover this topic in following points like epidemiology, clinical symptoms, normal anatomy, role of imaging, types, staging, recurrence, and the fertility sparing surgery if role is there. Epidemiology, madam has covered this also in the previous talk. Cervical cancer is the fourth most common cancer worldwide, second most common in India, more than 25% of the cases, third most common gynecological malignancy after endometrium and the ovarian. Average age of onset is around 45 years. Fourth cause of cancer deaths in female worldwide. Cervical cancer prevalence is strongly related to socio-economic status, leading cause of cancer deaths in some low-income countries, decline in deaths in developed countries due to screening, and 5-year survival rate 46% in India, lower than most countries. Risk factors: HPV 16 and 18 infections, multiple sexual partners, young age at first intercourse, high parity, immunosuppression, certain HLA subtypes, oral contraceptives, nicotine and smoking except for the cervical adeno, prevention possible with HPV vaccines and HPV DNA-based screening. Pap smear is replaced with cervical screening test. Pathology: invasive cervical carcinoma is thought to arise from transformation of the CIN, that is cervical intraepithelial neoplasia. 75 to 80% are squamous cell carcinoma, 20 to 25% are adeno, and others are also there. Location: cervical squamous cell carcinoma arises from the squamocolumnar junction, while adeno arises from the endocervix. The squamocolumnar junction is situated in the ectocervix in younger patients, though regresses to the endocervical canal with the age. Hence, cervical cancer tends to be exophytic in the younger patients and endophytic in the advancing age. We'll see how it presents, like patterns of the growth. The one previous. This. Okay. This is a slightly hyperintensive lesion compared to the rest of the cervical myometrium. This is exophytic growth. This is involving the posterior lip of the cervix. This is exophytic growth common in the younger patient, and this is circumscribed hyperintense mass within the endocervical canal, offsetting in the internal os, and such kinds of growth are common in the older patients. This is the infiltrative growth involving the cervix as well as extending to the body of uterus. Clinical symptoms may be asymptomatic, intermittent bleeding, postmenopausal bleeding, postcoital bleeding, dyspareunia, vaginal discharge, subclinically, and abnormal cervical cancer screening test. Imaging modalities: you can have USG, CT scan imaging, MRI, as well as PET CT. USG, you can see the lesion on ultrasound, less than 4 centimeter or more than 4 centimeter. You can also see parametrial invasion, invasion into the vagina and extension to the other organs, as well as you can see hydronephrosis because of the invasion of the ureters. CT imaging is available easily, but because of the radiation risk is not preferred. In general, it's not useful for the assessment of the primary tumors, but can be useful in assessing advanced disease. It is performed primarily to assess lymphadenopathy, but also has roles in defining advanced diseases, monitoring distant metastasis, also helpful in planning the placement of radiation ports and guiding percutaneous biopsy. MRI imaging is the preferred imaging modality of choice because of its inherent capability of detection of the cervical carcinoma, because of its ability to assess soft tissue in details, allowing detection of the stromal and the parametrial invasion. MRI had a sensitivity of 100% and a specificity of 85.7% in detection of parametrial infiltrations, and sensitivity of 100% and specificity of 90% in detection of vaginal infiltrations. It is sensitive and specific 100% in detecting tumor extension to the stroma, urinary bladder, and rectum. PET-CT in conjunction with the pelvic MRI is often used in imaging strategy for helping staging cervical carcinomas. FDG PET-CT has the overall best diagnostic performance for depicting nodal disease. Anatomy of the cervix, we are all aware, this is the cervix with internal os, external os, vaginal canal. We see how it looks on imaging. First is anatomy on the ultrasound. The crowd gathered is very well aware of how it looks on ultrasound. This is the fundus, this is the cervix, triple line endometrium on the TVS on the right side, how it looks on the transabdominal. This is urinary bladder, body of the uterus, cervix, vaginal canal, and on both sides ovaries. On CT imaging, you can see on sagittal scan, this is the body of the uterus, and this is cervix, vaginal canal, this is the urinary bladder, this is sacrum, and posteriorly is the rectum. And on transverse section, axial section, this is the cervical canal and both sides, both ovaries. On MRI, see how beautifully it depicts the anatomy. Anteriorly, from anteriorly, we will go. This is pubic symphysis, urinary bladder. This is the uterus as such. This is fundic portion of the uterus. This is the cervical canal. And this is the endometrial canal. This is junctional zone. And this is vagina. This is anterior wall. This is posterior wall. This is posterior fornix. This is anterior fornix. And this is colon. And posteriorly, it is there is a sacrum. And on transverse section, you see the cervix in transverse section. This is the junctional zone, the black line. And the center, it is endometrial canal. And on both sides, these are the ovaries. On coronal sections, again fundus, this is endometrial canal, cervix, junctional zone. And on this is again the junctional zone and the stroma of the cervix, and the ovaries on the both sides. Staging. FIGO, International Federation of the Gynecology and Obstetric, updated in 2018. The prior 2014 FIGO system was revised to incorporate imaging and pathological findings into the new system. 3 subgroups were created for the stage 1B disease, and incorporation of the lymph node status into stage 3 disease. For cancers to be seen on MRI, it has to be the stage 1B and above. MRI is the modality of choice for evaluating locoregional extent. You generally use diffusion weighted imaging along with T2 weighted imaging for the improved delineation of the tumor margins. And you're supposed to take axial sections, like this is cervix. You have to take axial sections to cover the cervix and the parallel sections in a sagittal plane to cover the entire anatomy. Generally, the tumor appears iso, intense on T1, hyper intense on T2, and if use contrast, they are enhancing. And on diffusion, it shows restricted diffusion. Stage 1, carcinoma is strictly confined to the cervix. 1A microscopic, 1B tumor confined to cervix with major deepest invasion less than or equal to 5 millimeter. 1B1, 1B2, and 1B3, 3 categories. Fertility sparing is possible in 1B1. Stage 1B changes made to the FIGO. Stage 1B disease, invasive cervical carcinoma limited to the cervix, now includes 3 rather than 2 subgroups based on tumor size measures in maximal dimensions. 1B1 less than more than 5 millimeter and less than 2 centimeter. 1B2, tumor between 2 to 4 centimeters, and 1B3, tumor more than 4 centimeters. You can measure the dimensions in any maximal plane, and it allows risk stratification for the treatment. Now, these are few cases of the stage 1B disease. You see a hyperintense lesion involving the anterior wall of the cervix, and on diffusion weighted it appears hyperintense. That is diffusion restriction, and it is not invading any other structure. So this is less than 1 centimeter lesion. Stage 1B2, the lesion is this lesion, exophytic in nature. Exophytic in nature, it involves posterior wall of the cervix, and it is displacing the vaginal wall, posterior vaginal wall. This hypointense line is posterior vaginal wall, but it is not invading the posterior vaginal wall. It is just restricted to the posterior lip of the cervix. This lesion is IB3, more than 4 centimeter, extending into the vaginal canal, displacing the posterior wall of the vagina. Stage 2. Stage 2 disease is defined as a disease that extends beyond the uterus, but does not involve lower third of the vagina or does not extend to the pelvic side walls. The pelvic side walls, they consist of obturator internus and piriformis muscles, contains iliac vessels, pelvic ureters, lateral lymph nodes. There has been no change to the stage 2 between the 2009 and 2018 FIGO staging classifications. The stage 2A, upper two-thirds of vagina, and stage 2A disease involves upper two-thirds of the vagina. These stages further divided into two subgroups. That is, that depends upon if the tumor is less than 4 centimeter or it is more than 4 centimeter. That is stage 2A1 or stage 2A2. The distinction between the tumor smaller or larger than 4 centimeter is again made for prognostic purposes. Masses larger than 4 centimeters have bigger chances of recurrence, and they have a nodal metastasis than do tumors measuring less than 4 centimeter. These subgroups also serve to guide management. How to differentiate whether the tumor is invading the upper vagina or lower vagina? You're supposed to draw a line from the inferior margin of the bladder. That portion above this black line is upper one-third of vagina, and that portion below the black line is lower one-third, to differentiate it imaging wise. Stage 2A, now this lesion involving the cervix and upper two-third of vagina. Bladder is seen clearly. Stage 2B, parametrial involvement. The now parametrium comprises of fat, lymphatics, vessels located between the body of the uterus and the pelvic side walls above the level of ureters. At MRI, normal cervical stroma demonstrates low T2 weighted signal intensities. Focal or diffuse full thickness destruction of this low signal intensity stromal ring with tissue extending into parametrial fat is highly suggestive of the invasion. If there is a full thickness involvement of the cervical stroma but no invasion of the surrounding structure, then the microscopic, this parametrial invasion may not be present, and maybe microscopic disease extension cannot be excluded on MRI. This is the case of stage 2B. Now this is the cervix on the axial plane. Now this black junctional zone is totally invaded. The margins of the cervix are invaded and it is extending into the parametrium. So this is stage 2B disease. Stage 3. There are no changes made, no changes to the stage 3A and 3B, which have a natural progression from the stage 2, defined by the extent and the direction of the tumor spread. Stage 3C is completely new substage and constitutes the third change in the 2018 FIGO staging classifications. Stage 3A, lower one-third of vagina, the lower one-third of the vagina based on MRI evaluation, vaginal tissue below the level of the bladder base, and stage 3A disease extend to the lower one-third of vagina and is best appreciated to the sagittal sequence. Tumor demonstrate intermediate signal intensity on T2 weighted, and at this stage, vaginal extension can also be assessed readily at clinical examination. Now, stage 3A, you see this tissue, this is hypointense lesion involving the lower one-third of the vagina. This is the base of the bladder, and this is involving lower one-third of the vagina. Stage 3B, now on stage 3 there will be involvement of the pelvic side wall. It is defined in the 2018 FIGO staging classification as extension to the pelvic wall that may manifest with hydronephrosis because of the involvement of the ureters, or may manifest with non-functioning kidneys. Invasion of the pelvic side wall can be diagnosed on imaging when the tumor is less than 3 mm from the pelvic walls. Hydroureter or nephrosis secondary to the ureteric invasion is indicator of stage 3B. Now, on this sagittal section, you see this is dilated ureter, which is there because of the invasion, and this is the lesion. It is involving the internal os with collection in the endometrial cavity, and this is dilated ureter on the right side. Now, stage 3 C1 and C2. Pelvic and para-aortic lymph node involvement. The prognostic implication of the pelvic and para-aortic lymph node involvement have been extensively evaluated. There have been multiple studies showing increase in disease recurrence in the presence of positive lymph nodes at varying stages of local tumor extension, as well as reduced overall survival. Consequently, the stage 3 C1 and C2 have been added to the 2018 FIGO staging classification and manifest as pelvic and para-aortic lymph node enlargement respectively. Now, this is stage 3-1. You see the disease in the posterior wall of the cervix, and there are two lymph nodes, obturator lymph node on the right side and the iliac lymph nodes on the left side. On PET CT, uptake in the both lymph nodes. Now, stage 3C2, invasive mass in the cervix, extending into the body of uterus, obstructing internal os with collection in the endometrial cavity. There is a presence of lymph node in the right pelvic side wall. And on PET CT, you see the para-aortic lymph node uptake. Stage 4A, disease extending to the adjacent organs or outside the true pelvis as a metastatic disease is classified as 2018 stage 4. This classification remains unchanged. It includes rectal and bladder mucosal involvement, inguinal and supraclavicular lymph node, pulmonary, bone and other visceral metastasis. Stage 4A, extension of the cervical tumor through the full thickness of the bladder wall anteriorly or rectal wall posteriorly into the mucosa, and lumen constitutes stage 4A. There is some issue here. If you see the complete breach of the mucosa, then you can see it is invaded. But if the tumor is abutting the mucosa, but it's not extending, so clinically you have to assess the situation. Maybe clinicians will tell you, you have to go ahead with the scopies to see whether the particular bladder mucosa or the rectal wall is involved or not. Now, these are the cases of stage 4A. This is the lesion. This is a very popular bullous edema sign. You can see there are the inflammatory changes in the posterior wall of the bladder, but this does not indicates it is involving the vagina. This is secondary to the inflammatory changes in the bladder wall. And on the left side, you can see there is an invasion of the bladder wall because of the tumor. Stage 4B, this stage describes metastasis to the distant organs, either by lymphatic spread or distant lymph node groups. Stage 4B, bladder involvement, the few cases. There is a bladder involvement here, hydronephrosis, and again nodes. You can see the involvement of the rectum posteriorly. This pattern is lost here also, you can see here. Supraclavicular node on PET CT. Few cases of stage 4B on CT, involvement of the bladder wall and hydronephrosis because of the involvement of right UV junction. Now, lymph node status and number of lymph node involves most important prognostic factors. 5-year survival rate drops to 51 to 78% stage 1B, 2A disease with lymph node involvement compared to 88 to 95% without lymph node disease. Pelvic and para-aortic lymph node measuring more than 8 mm in short axis, particularly those with rounded configurations, spiculated or lobulated contours with similar signal intensity to that of primary cervical tumor are suspicious at MRI and CT and constitutes stage 3 C1 and C2 respectively. Diffusion cannot distinguish between the benign or malignant lymph node. Imaging pitfalls because of the biopsy. Sometimes you may confuse with the disease. So you are supposed to give some time between the biopsy and the time of the imaging. And the second point is technical. If you use large FOV for the true axial imaging, sometimes partial volumic artifact may give impression of parametrial or a local organ invasion. Treatment plan, Dr. Vipul will tell more about this. But the stage 1B, they consider surgery, and for invasions, parametrial invasions, pelvic wall and bladder wall involvement, after doing PET CT and assessing involvement of pelvic lymph node, para-aortic lymph node, distant metastasis, radiation therapy, and all those are advised. Recurrence, similar imaging features of primary, as similar to primary involvement. MRI is the modality of choice. Enhances and they have a low ADC values, but fibrosis doesn't enhance and have a low ADC value. Abnormal signals may persist after treatment. You're supposed to do PET CT 3 to 6 months after the treatment to demonstrate metabolic response. If no prior RT, combined with chemo RT. If prior RT, radical surgery is advised. You can see this is the tumor. And after giving, this is the tumor recurrence, this is the tumor involving the cervix, and contrast is giving, this is enhancement, this is recurrence of the lesion. And this is the tumor before radiation, and after radiation it is totally regressed to the hypointense cervical stroma. So essential elements to be included in reports: tumor status, whether it is limited to cervix or there is a spread to parametrium, actual size, status of the distal ureters, pelvic side walls, spread of the tumor to the local or distant organs, and involvement of pelvic and para-aortic lymph nodes. Summary: cervical cancer, MRI standard of care for staging, assess for fertility sparing surgery if possible, assess if surgical candidate. Thank you.
Nicely explained. Definitely the advanced imaging techniques, adding a lot to the clinical diagnosis, clinical staging, more specific, definitely helpful in planning the treatment, specific treatment. Very nice lecture, sir. Elaborate. Any questions?
Thank you, everyone. I request our chairperson and Dr. Anjali Chamma, please felicitate Dr. Vaibhav Meru.
Our next speaker is Dr. Vipul Doshi sir. He is consultant medical oncologist, presented many papers and posters in various CMEs, and he is author of Indian Journal. And he will enlighten us on overview of medical treatment in gynecologic malignancies. Over to you, sir.
A very good evening to all. I would like to thank Solapur Obstetric and Gynecological Society for giving me an opportunity to express my views on overview of medical management in a gynecological malignancies today's talk, I'll more focus on the what is the medical management or oncological management in the gynecological malignancies, more focused on the cervical cancers. So today I'll be discussing more focused on the cervical cancer, some part of ovarian cancer treatment, some part of uterine cancer treatment, and some part of gestational trophoblastic neoplasms. So first we'll look forward to the cervical cancer, and if you look at the statistics, India is the third. In India, it is the third most common cancer, and the incident rate is almost 1,20,000 cases every year, and it is the second leading cause of death. And if we look at the mortality, it roughly accounts for 9.1% of all cancer mortality as per the Globocan data in 2020. And it is sad that majority of cervical cancers in India are usually diagnosed at the locally advanced stage. If we look at the data, almost 60% of patients are usually get diagnosed at the locally advanced stage. Usually a patient presents as either as a postmenopausal bleeding or a discharge or a postcoital pain or dyspareunia or postcoital bleeding, and on a clinical examination they are found to have an induration or a growth, and subsequently evaluated for further testing, and it has been done. So by and large for a cervical cancer, most emphasis is on the clinical examination, or what we call it as a PV, PS and PR examination, which determines the stage of the disease, and it should be combined with the imaging or a PET CT scan in appropriate settings. So cervical cancer stages already has been discussed in detail by Meru sir. To summarize it, for a stage 1, it is a localized cancer, localized to the uterus. 1A disease, a very small disease. 1B disease, a big disease, but confined to the cervix or confined to the uterus. Stage 2 disease is a spread beyond the uterus, either to the part of the parametrial or the vagina. Stage 3 disease is a more locally spread disease, which should involve either extension up to the pelvic wall or involvement of the lower 1/3 of vagina, or there is an involvement of pelvic or para-aortic lymph nodes. Stage 4 disease it has a subtypes, either stage 4A, which has a spread to the local pelvic organs or adjacent pelvic organs like bladder or rectum, and stage 4B is a spread to the distant organs. Cervical cancer treatment by and large depends on the FIGO staging. For stage 1A1 disease, either local therapy, cone biopsy, extrafacial hysterectomy, hardly any need for lymphadenectomy. It's a very early stage and very rare to get diagnosed. In the stage 1A2 disease, either a trachelectomy or modified radical hysterectomy, and it requires pelvic lymphadenectomy. From stage 1B1, trachelectomy, radical hysterectomy, and pelvic lymphadenectomy. From stage 1B2 onwards, it requires concurrent chemoradiotherapy. Usually cisplatin-based chemotherapy is used along with the staging. In some cases, pelvic and para-aortic lymphadenectomy is needed. In a metastatic disease, chemotherapy alone and only local treatment for primary cervical lesion, either for a pain control or a bleeding control. So let us come to what is the medical management in the cervical cancer. So we look at the role of the chemotherapy or medical management post-surgery in the form of adjuvant chemotherapy. It is given along with the radiotherapy, what we call it as the concurrent chemoradiotherapy. We usually use a weekly cisplatin-based chemotherapy in a following indications, like there are absolute indications like margins are positive, or lymph nodes are positive in the lymph node dissection. These are the absolute indication. There is a definite requirement of chemoradiotherapy in these scenarios. There are some relative indications where we can consider giving concurrent chemo and radiotherapy, like if the histology is adenocarcinoma or small cell carcinoma or neuroendocrine tumor, or there is a poorly differentiated morphology, or there is a presence of lymphovascular invasion or perineural invasions. So these all are indications for using adjuvant chemoradiotherapy post-surgery in an early stage disease. For stage 1B to stage 4B disease, we usually, the treatment is confined as a concurrent chemoradiotherapy, in which we give radiotherapy daily, on daily basis, up to 25 to 28 fractions from Monday to Friday, and Saturday, Sunday there is a gap. Concurrently, we give simultaneously chemotherapy once in a week, almost 5 to 6 or maximum 7 cycles we usually do give. I use cisplatinum in a fit patients, usually very well tolerated, hardly any major toxicities are seen in this type of treatment. In a unfit patient or a poor patients, poor general condition, we use carboplatin instead of cisplatin. So we choose depending on the age, comorbidity, and a creatinine clearance. In some cases, or when the performance status is poor or general condition is poor or the elderly, I give only radiotherapy also in these scenarios. Then we look at the role of the neoadjuvant chemotherapy. What we mean by neoadjuvant chemotherapy is prior to any definitive therapy, we give chemotherapy first. So what we call it as a neoadjuvant or anterior chemotherapy. And there are some absolute indications, like in a stage 4 disease, when there is a bladder or rectal invasion. So if in this scenario, we usually prefer giving chemotherapy first. What happens if there is a bladder or rectal invasion of the disease and we start concurrent chemoradiations, many of the patients tend to develop fistula formation, either vesico-vaginal fistula or a recto-vaginal fistula, and then the life becomes miserable. So in this scenario, we do give chemotherapy first to downsize, to downstage the tumor, and at the end of the 3 to 4 cycles, we assess the disease, and if there is the tumor becomes free from the bladder or rectal, then we can consider giving them a definitive chemoradiotherapy. There is another more indication, presence of bulky para-aortic lymph nodes. Bulky means size is more than 3 to 4 centimeters. What happens? The para-aortic lymph nodes are near to the renal vessels, near to the kidneys. And in a case of radiotherapy, we cannot irradiate kidneys. So like we always have to irradiate the portions below the kidneys. In these scenarios, we have to come down on size of the para-aortic lymph nodes to make them to fit into the portal of the radiotherapy. So in that scenario also, we give neoadjuvant chemotherapy. We usually give 3 to 4 cycles every 3 weekly. It's a one-day admission. We usually agent use as a taxane and platinum based. Usually very well tolerated chemotherapy. We hardly do any major side effects with this. We see common side effects like hair loss, nausea, vomiting, pain, but hardly anyone requires admission because of the side effects. So it's a very well tolerated, very well useful drugs, taxane and platinum in these scenarios. There is one more indications prior to surgery, although this is controversial now and not a standard of care, but it still can be considered in the stage 2 or 1A, 1B bulky disease to downsize, to downstage the tumor to make the tumor operable. So even in that scenario, same the combination has been used. We usually use 3 to 4 cycles of taxane and platinum based combinations. Then we come to the last part, palliative chemotherapy in a recurrent cases or in a metastatic cervical cancers. It has its own benefit, improves the symptomatic, the pain control, the discharge control, the bleeding control. It gives a better quality of life and it makes patients survive longer. So if we look at the recurrent or metastatic cervical cancer, without treatment, there is a life expectancy in the range of 3 to 6 months. So with chemotherapy, we can improve life expectancy from 1 year to 2 years. So this is what benefit we can get from chemotherapy. For a chemotherapy, we use a different combination depending on the situation, the disease burden, or the fitness of the patient. So taxane, platinum, 5-fluorouracil, gemcitabine, liposomal doxorubicin, we usually use in different combinations. And again, this, as the time goes, initially in a first line, it responds well to the chemotherapy. There will be some chemo-free period, then again it relapses, we have to choose second line therapy, we have to choose third line therapy, and subsequently it goes on for 1 to 2 years. There are some recent advances in cervical cancer in the form of medical treatment. One is a targeted therapy. There is a use of bevacizumab available with us, which is actually a VEGF inhibitor, vascular endothelial growth factor inhibitor. It reduces angiogenesis in the tumor stroma. So it reduces the feeding vessel to the tumor, and thus it makes the tumor dry, and that is how it reduces the tumor. It usually used in a metastatic setting along with the chemotherapy. It helps in a early and deep responses and to make them survive longer. Alone chemotherapy, alone targeted therapy or bevacizumab or this is very well tolerated, but it is definitely better tolerated than chemotherapy. So in some cases who are not fit for chemotherapy, we do consider giving targeted therapy alone or in some low dose chemotherapy. So it helps to reduce us to dose of the chemotherapy to make them tolerable, make them use for the patient. There is one more recent advances has been done in cervical cancer in the form of immunotherapy. The drugs were approved currently available in India are pembrolizumab and nivolumab. These are the PDN or PDL1 inhibitors. PDN, PDL1 stands for programmed death receptors. Actually, in every tumor, there is a innate immunity response. There are cytotoxic T cells and NK cells which reduces the tumor, but the tumor's trauma has this PD and PDL1 receptors which causes inhibition of these anti-tumor NK T cells and thus causes rise in tumor. So what this pembrolizumab and nivolumab done, it inhibits the PDN and PDL1 and thus it improves the cytotoxic or cytotoxic cells anti-tumor response. Currently, it is being used in a metastatic disease either alone or along with the chemotherapy. Again, it is a very well tolerated drugs, better than a chemotherapy. Some patients do tend to develop some autoimmune side effects because it enhances immunity. Then we'll come to the brief review of the other cancers. Like the second most common cancer is ovarian cancer. It is the 8th most common cancer in India. There is an incidence roughly around 60,000 new cases at the end of the 2020. And the ovarian cancer is estimated to be increased almost by 5-folds by 2035. And the death rate is expected to increase by 5-fold in 2035. So majority, even there is a problem with the ovarian cancer, the majority of usually get diagnosed at the advanced stages. Almost 80% of ovarian cancer tend to diagnose at stage 3 or stage 4 disease. Usually middle-aged female presents with the abdominal distension, decreased appetite, early satiety, constipation, and some vague symptoms, and subsequently tend to diagnosed as a peritoneal disease or ascites or ovarian masses, and then it get diagnosed. For epidemiology, in ovarian cancer, it has been is a huge mix of cancers. Basically, is pathologically, it has epithelial cancers like adenocarcinoma, which can be serous or mucinous, or endometrioid, or it can be clear cell carcinoma, or it can be carcinosarcoma. The most common is a serous adenocarcinoma, and the second most common is a mucinous adenocarcinoma. And the age of diagnosis is roughly in the range of 50 to 60 years. The next most common cancer is a germ cell tumor, ovarian tumors. They usually tend to occur in a younger age group from 10 to 30 years. It either has a dysgerminoma, a yolk sac tumor, a mature teratoma, or a choriocarcinoma. Then the less common tumors are sex-cord stromal tumors, kind of a granulosa cell tumor or a sertoli cell tumor. The age, it actually varies from the which subtype, usually can seen in the perimenopausal woman. And there are other rare tumors which can be either Krokenberg, which comes from the other sites like lung, like stomach, from intestine, from rectum, or it can be Brenner's tumor. For a staging purpose, we usually ask for a biopsy or a peritoneal fluid cytology, and for imaging, we usually ask for a CT scan for the diagnosis of these cases. For by and large, overall, stage 1 disease is confined to the ovaries. Stage 2 disease is spread to the pelvic area. Stage 3 disease involves both outside the pelvic area in the form of peritoneal metastasis or a peritoneal lymphadenopathy or gross ascites. Stage 4 disease is a distant metastasis which includes liver parenchymal metastasis or a pleural effusion. As a management point of view, surface ovarian neoplasms, which includes high-grade serous and mucinous, usually stage 1 and stage 2 and a very early stage 3, stage 3A directly goes for the surgery, and after surgery, some of them requires adjuvant chemotherapy, like from post-surgery 1C onwards, or high-grade serous variety tumors requires adjuvant chemotherapy. The adjuvant chemotherapy is been given to reduce the recurrences for the ovarian cancers. For stage 3C onwards, there is role prior to the surgery to downsize, to downstage the tumor. Then after 3 to 4 cycles of chemotherapy, we tend to do interval cytoreduction surgery, which removes ovaries, fallopian tubes, omentum, hysterectomy, peritoneum, and all the visible deposits from the abdominal cavity. And after that, we again give 3 to 4 cycles of chemotherapy to prevent or to reduce recurrences. Even the chemotherapy is given in a palliative setting, in a recurrent setting, in a metastatic setting. And the commonly used agents are taxane platinum for 3 to 6 cycles in this scenario, which is most commonly used agents. Then ovarian neoplasms like germ cell tumors. These includes dysgerminoma, immature teratoma, or yolk sac tumors. There is a role of chemotherapy after surgery in a dysgerminoma, immature teratoma. For low grade, stage 1C onwards requires adjuvant chemotherapy to prevent recurrences. For all yolk sac tumors and choriocarcinomas and mixed tumors requires chemotherapy post-surgery. There is some role prior to the surgery in stage 3 or more, and in some cases we can consider doing a unilateral salpingo-oophorectomy, what we call it as a fertility preserving surgeries. In that scenario also, we give chemotherapy first, we downsize the tumor, and we can do fertility preserving surgeries. The commonly used agent in this scenario are the bleomycin, etoposide, and cisplatin, 3 to 4 cycles. Usually given long course chemotherapy, 5 days chemotherapy. It's a quite toxic one chemotherapy, but usually given in young patients, they tend to do tolerate well. Then there are rare neoplasms like sex cord stromal tumors, granulosa cell, theca cell, or Sartori Leydig cell tumor. And it again requires adjuvant chemotherapy from stage 1C onwards. And from stage 3C onwards, it requires prior to the surgery. And again, the agents were used in older people. We tend to use taxane platinum based combination because it is well tolerated. In a younger patient, we use bleomycin, etoposide, platinum combinations for 3 to 4 cycles, because in young patients they tend to tolerate this combination chemotherapy well. Then we'll briefly overview uterine cancers or endometrial cancers, which has a high grade serous, endometrioid, which is a most common type of cancer, and there are some carcinomas and mixed carcinosarcomas and some low grade ESS. So usually uterine cancers tend to present as a post-menopausal bleeding, and subsequently they undergo curettage, and subsequently they tend to diagnosed as endometrial cancer. Then the staging has been done, and after the staging, maximum usually do presents in an early stage, and they post surgery, few of them requires chemotherapy. For example, for those who has high grade tumor requires chemotherapy, for endometrial but high grade requires chemotherapy, carcinosarcoma requires chemotherapy, all those who have lymph node positive means stage 3 onwards requires chemotherapy. There is no role of chemo in giving low grade endometrial stromal sarcoma, but hormonal therapy is beneficial in this scenario. Chemotherapy is used again in a palliative and recurrent setting. Again, the treatment combinations are usually used as the taxane platinum based combinations, and in stage 1B onwards endometrial low grade or intermediate grade, we usually tend to give concurrent chemo or radiotherapy. In that scenario, the agents used are cisplatinum. Then there are other rare types of uterine cancers, in which sarcomas, in which most common is leiomyosarcoma. Post-surgery upfront, there is no role of adjuvant chemotherapy or radiotherapy in leiomyosarcomas. A complete surgery suffices the treatment of the leiomyosarcoma. Chemotherapy is only used in a palliative intent or recurrent and metastatic settings. The usually used agents are ifosfamide or adria-based or gemcitabine docetaxel-based chemotherapy. There are other rare sarcomas like low-grade endometrial stromal sarcomas or rhabdomyosarcomas or Ewing or high-grade spindle cell sarcomas, but which are usually treated individualized as a case-to-case basis. Towards the end, gestational trophoblastic neoplasm, which either we call it as an invasive mole or a choriocarcinoma, which is again seen in a pregnant woman, which usually requires WHO scoring for determining it's a low risk or a high risk. For low risk gestational GTNs, we manage with a single agent methotrexate or a dactinomycin based protocol, and for a high risk or we can see who had spread beyond the uterus, either in the form of liver metastasis, lung metastasis or brain metastasis, requires multi-agent chemotherapy like kind of IMACO protocol. There are others like complete mole or non-invasive mole or placental site trophoblastic tumor or endometrial trophoblastic tumor, which actually does not require chemotherapy. Surgery usually suffices for them. Thank you.
Explained, sir, role of chemotherapy prior to surgery or even post surgery also. It is very, very essential. Any questions, sir?
Good. It was really a very elaborative and comprehensive talk on all malignancies, Vipul. And yeah, just wanted to know about this CA cervix and chemotherapy. We have been taught since years that the radiation is the main thing which is required for the CA cervix. But when this chemotherapy role started appearing in the literature or in the practice of chemotherapy as well for the CA cervix?
So like if you say for a age-long practice, it was like from stage 1B onwards till stage 4, it was radiotherapy and concurrent with chemotherapy, it was our only role. But what people had seen, when there is a rectal invasion, when there is a bladder invasion, there is a tend to develop fistula formation, and that makes very difficult life for the patients. So from that day onwards, they have started to giving anterior chemotherapy to reduce the tumor size, to reduce the stage, and after the reducing stage, the risk of the fistula formation decreases. What we can see as a local control increases. So in that scenario, actually the chemotherapy role comes. The other part is the lymph node involvement. What happens now, along with the time, what we have seen, the cervical cancers with the para-aortic or pelvic lymph node involvement, they tend to have high chances of recurrences and less survival. So in that scenario also, currently the things are being investigated for using a chemotherapy, because the chemotherapy is a systemic agent and it usually takes cover of all what we call it as a micrometastatic sites, or what we call it as a lymph nodal metastatic sites. So in that scenario also, the more and more chemotherapy role is upcoming. The other part is concurrent with the radiation therapy. What happens now, if we give radiotherapy alone and if we give radiotherapy concurrently with the chemotherapy, what chemotherapy does, it decreases the tumor burden, one thing, because it's an anti-cancer agent, but the other thing what it does, it makes tumor cells more sensitive to the radiation. So what we call it as a radiosensitizer. So the radiation effect becomes much better. So thus the chemotherapy roles are coming and coming and coming. And now in this presence of this immunotherapy and the targeted therapy, of which immunotherapy is coming even in the earlier stages. Like people are now trying using immunotherapy even in earlier stages of cancer to make what we can call it as a cancer more amenable for better treatment.
Can you have a little more elaboration about the immunotherapy, because nowadays, especially for the CA, lung and many other malignancies, even gynecological, a lot of discussion is happening on the immunotherapy. So can you tell a little more about that?
What basically we have seen in immunotherapy, the concept is that normal tumor stroma has lot of CD8 and natural killer cells, and which has a good anti-tumor response. But subsequently it has been inhibited by this programmed death inhibitor, PD and PDL1, and there are a number of other factors like CTLA4, there are a number of other cytokines which actually inhibits this natural killer cells and T cells. So what now the people are trying to enhance this type of immunity with multiple levels. So this what I have said is a pembrolizumab or a nivolumab is a antibody to these inhibitors, to PD-L1 antibody and a PD antibodies, which actually it improves or anti-tumor response of these cells. Thus, our natural immunity kills the tumor. So this is what the concept. So this is one part of immunotherapy. There are also multiple things are being tried at these stages. So now what we are looking at some vaccines we are using it for prevention of disease, but now we are looking at some vaccines to produce good immune response to reduce the size of the disease, to reduce the burden of the disease. So like in this kind of situation, and it is coming in many of the cancers. It is now most commonly used in the skin cancer and the lung cancer, and in what we can gynecological malignancy. Currently it is indicated only in this cervical cancers and in some tumors of endometrial cancers, those who had associated with Lynch syndrome. So we had seen that the people who had associated with Lynch syndrome tend to have better responses with immunotherapies. So currently it is indicated in both those two scenarios only, but it is in experimental stages at lot of phases. So with time the indications will increase.
Any questions?
Vipul, how much is cost of bevacizumab?
Bevacizumab cost, when the Avastin was launched, the cost of 400 mg vial was 1.5 lakh per vial. But now the generics are came, so now it costs roughly between 12,000 to 15,000 per cycle. So that is like usually women require 7 milligrams per kg dose. So I think usually 500 to 600 mg dose comes between 15,000 to 20,000. So which is well affordable.
Thank you. I request our chairperson and Dr. Anjali Jama ma'am, please felicitate Dr. Vipul Doshi sir.
Last our last speaker is, because of some reason he will join online, Dr. Nikhil S. Parvate. He is a senior consultant, gynec-oncologist, head of robotic surgery services, head of colposcopy services, co-chair of tumor board committee, and Aditya Birla Memorial Hospital, Chinswad. He is working at Aditya Birla Hospital, and he is a FOXY approved trainer of colposcopy, completed 900 gynec-onco surgeries and 8,000 colposcopies and related procedures. Over to you, sir. Hello? Your voice is not.
Hello, am I audible now?
Yes, sir. Yes, sir. We can start, sir.
Okay, somebody please enable me to do screen sharing because it is saying that host disabled participant screen sharing. So if you can help me with the screen sharing.
Sir, we've made you the host. You can try sharing the screen now.
Okay. Is my screen visible?
No, not it. Yes, it's visible now.
Okay, good evening everybody at SOGS. I apologize for not coming to Solapur because there are certain audits going on in my hospital, so I couldn't join you. I thank Deshpande Madam, President SOGS, and Monica for giving me this opportunity to talk to you. Can I start? Is my slides visible?
Yes, sir, we can start.
Okay. So the topic that was given to me was the correct approach. So after listening to previous talks, I will now come back to hard facts that as a gynecologist, everybody needs to follow in the consulting rules, because cervix is the only topic, is the only amongst the gynecological cancers that can be managed completely by gynecologists. So before any talk on cancer cervix is without these people. Can anybody identify this gentleman in the audience? This is Professor Shorta. This is Professor Vardhines. He's a student of Dr. Shorta. And of course, after this, a lot of people came in and did a lot of modifications of Vardhines. Me is the one which we routinely follow. Anybody for this? I think this gentleman, most of you might know. Herald Zonhausen. He's won Nobel Prize for linking CA cervix to HPV virus. So he's the one who isolated and detected HPV virus, and that's what is in his hand, a Nobel Prize in 2006. So any talk on cancer cervixes cannot be, going ahead without these gentlemen. We need to know them. I do not have any conflict of interest in this lecture. We all know about the natural history of cancer cervix. It is mostly a local spread. So what we actually anticipate is cervix going into the parametrium, going down into the vagina, going up into the uterus, and then through the lymphatic going up to the nodes. And lastly, we have the vascular spread. And we all need to understand that even in stage 1 disease, we have about 15% of pelvic lymph node involvement and up to 5% of para-aortic lymph node involvement. That is the key message from this point. Hematogenous spread is probably when the earlier speaker was talking about stage 4 disease, is where the hematogenous is last phase. So it is more of a local spread followed by lymphatic spread. So that is how the CA cervix spreads. Now, this is very important for us because cervix is so easily visible to us, and everything in CA cervix is clinical. Everything. So we have in our hospital a proper tumor board proforma on how we do evaluation in patients of cancer cervix. Most important is if you see a growth, please do not send those patients for colposcopy, because even today in Pune city, if somebody sees a growth patient, they are referring the patient to me for colposcopy. There is no need for colposcopy in a visible growth of the cervix. So that is the first thing. There is no role of transvaginal sonography for cervix. This is not an obstetric cervix. This is a gynec cervix. So transvaginal sonography has zero role. So what has a role is a per speculum examination. So per speculum examination will help you identify most of the cancer cervix. What has happened is we tend to hear that we get a lot of CA cervix in late stages. Well, I have changed that in my hospital. I am getting a lot of them in early stages because I have made very stringent changes in screening and colposcopy. And because of making these changes, we are picking up 1A1, 1A2, 1B1. So when I joined the hospital, in 1 year, I used to do some 7 or 8 Vardhines only. Now, after that, I understood that most of these patients are going to the radiation and medical oncologist because of being advanced. We thought about it. There was no screening and no colposcopy space. I have made it so stringent that not a single woman coming to the hospital, wherever she goes, even if it is going to the gastroenterologist, nephrologist, doesn't matter. If she has not screened, she has to come for screening and she has to undergo colposcopy if the screening is positive. So we are picking up more of stage 1 diseases, and it's coming to the gynec oncology department. So what are the clinical presentations? We all know a post-coital bleeding, intermenstrual bleeding, a white discharge. Again, in it being a corporate setup, we are completely away from those foul-smelling vaginal discharges coming to us. We are completely out of it also. So clinical presentation, whenever any women is coming with these complaints, the first thing which is mandatory is a per speculum examination, which majority of the gynecologists are avoiding, and they are replacing it with a transvaginal sonography. Believe me, there is no information on transvaginal sonography because CA cervix is all epithelium based. Sonography does not tell you anything about the epithelium. There are some places where even when the patient comes for a per speculum examination, even the colposcopic evaluation is done there and there itself. So our aim as the gynecologist, your aim should be very clear that lots and lots of screening, lots and lots of colposcopies. We do not want stage 3, stage 4 because this is the only preventable cancer and which can be 100% prevented. So please do, that sonography report telling something in the cervix is the most untrustworthy thing. It is your per speculum examination which is 100% trustworthy. So all lesions of the cervix, because as I said, it is an epithelium based pathology. So anything which is epithelium and when it is clearly visible to you, you focus more on per speculum examinations. Now what happens is sometimes if you see a growth on the cervix, okay, what you need to do is, if you find that a growth is less than 2 centimeter, many a times what I do is I generally take a controlled OPD basis biopsy. Okay, I'm trained to do so, so I know how to do it. If at all you find that no, this OPD based biopsy may make the patient bleed or so, the next step and most important step which everybody omits is a EUA. The amount of information clinically that you get in an EUA is much better than the MRIs also. So as I said, it's a clinical examination. So at EUA, you can also put in your colposcope. Okay, you can take a proper biopsy. If the biopsy bleeds, you have other ways of stopping that bleed. And most important, you always apply Lugol's iodine. I have never done MRI in my life for CA cervix, nor will I ever do it. What I do it, EUA, apply Lugol's iodine to the vagina, and that will tell you whether the upper third or the lower third of the vagina is involved. Because anything which is iodine uptake negative, that is yellow area, is involved. So at EUA, you can apply Lugol's iodine, you can see the vagina, you can, when the patient is relaxed, you can completely see the cervix, see the fornix, you can see how much is the size of the tumor, and most important, as clinicians, we are supposed to be in OPDs and theaters, not in the AC rooms. So most important things is PR examination. Again, my findings, I know I'm very clear about my PR findings. I need not do an MRI to understand whether the parametrium is involved or not. My PR findings on an EUA gives me a very good amount of knowledge of what the parametrial involvement is. So this is what you need to do when you see a cervical growth. Most important, if the patient is complaining of torrential bleeding or heavy bleeding, postcoital bleeding or polymenorrhagia, menorrhagia, if there is any suspicion of possibility of cancer cervix, what I will say is avoid a per speculum examination in the OPD, do a PR examination. Now, I think I have almost stopped doing PV examination. Most of my clinical findings are based on PR examination, which gives me much more better idea than a PV examination. So you can do that and again avoid torrential bleeding. Second is taking biopsies. So when you're doing, and please understand, if you see something suspicious in the cervix, please do not send patients for CT, MRs and PET. You cannot have a system where imaging is first and biopsy is second. That is wrong practice. So it has to be biopsy first, cancer proven first, and then imaging. Because many times I get a report that it means patient is not even examined, not even a PS, but just because sonography said that there is something suspicious, send the patient to MRI, and then if there is something malignant written, send it to the oncologist. This is the wrong practice. And if I get such patients, I call up the gynecologist and say, don't do this. So the first thing has to be histo, because if there is cancer, then only you will do staging or whatever you want to do. Before that, how can you do imaging? And please don't have so much of fancies of imaging. Even if you're talking medical legally, if it comes to me as a legal expert, I say if few imagings are not done, it's fine. So please take a biopsy, and biopsy should be a good chunk and hopefully reported by a experienced oncopathologist if it is available possible, or at least who has some idea training about reporting a cancer pathologies. So at EUA, you also get the advantage of doing biopsies. So biopsy, vagina, parametrium, avoiding bleeding, so many things can be done in only one EU examination that doesn't take you more than about 10 or 20 cc of propofol or 2 cc of a Voveron or a Fortin, and a patient going home back with lot of loaded information in one visit. And once the histopathology report comes that there is a cancer, then you think of what imaging has to be done. Now, if during local or EUA examination, if you find that a vagina is already involved, whether it is upper third, the stages have been discussed, so I'm not going to talk about it. Whether it is the upper third or the lower third, if the parametrium is involved, you know that probably this patient is going to definitely go for a concurrent CT-RT. So you may even do a plain CT and go about it. So you need not do a very high advance, because whether it is 3C or 2B or 3B or 3A or 3B, idea is concurrent CT-RT. But please understand that what I see is a lot of time wasted in this imaging and trying to find out what it is, rather than taking simple biopsies and proving. For me, if a cancer, if a growth comes to me, it is one day that everything is done for the patient. One day, everything is done for the patient. Why? Because cervix is completely clinical. So please start thinking about getting EUA in your practice. If not, then at least call someone who will help you do an EUA, and that is how we'll diagnose most of them. Already, I guess there was a lecture on imaging. So what is the protocol of my tumor board is, my diagnosis is, it is the patient comes to me. The patient does not go to the radiation or the medical oncologist. It comes to me. So that's the rule that we have fought and made it in our hospital. So once it comes to me, I do a complete clinical evaluation, do a biopsy, prove it with a biopsy. If I understand that as it is about 2B, 3B, 3A, and all these things, I do a basic CT scan and send them to the medical and the radiation oncologist to give concurrent CT-RT. Now, there is a situation where we can do PET also. We are doing PET in our, because PET is given at a very low cost at our hospital because of CSR basis. The reason that PET has come into play is because of the 2018 FIGO classification staging of CS cervix, where 3C1 and 3C2 has been put as pelvic and para-aortic lymph nodes. If you see the earlier classification, there were no lymph node in the staging of cancer cervix. Now in 2018, they have got 3C1 and 3C2 as lymph nodes. Now, if you need to find out about lymph nodes, then PET is the correct method of staging, okay, to find out. But where PET is not available, a good CT with contrast should also be able to pick up nodes. So what we do is a good clinical examination with EUA and a PET CT is our method of evaluating or staging a cancer cervix patient. So a complete EUA will give me. The only thing is, sometimes a medical oncologist, radiation oncologist decides not to do PET, because already, if I have said it has gone into the lateral pelvic wall, which is 3B, what more, even if the node is positive or negative, things are not going to matter, as the treatment is not going to matter. As far as prognosis is concerned, remember one thing, what happens in private patients is we have CA cervix straight going, not going lateral and up, straight going to the lymph nodes, without going to the parametrium, without going to the vagina. Now, if they are going straight into the lymph nodes, without the parametrium and vagina, these are the ones which are having better prognosis in spite of lymph node involvement. But if you have the one going to the parametrium, vagina, and then to the lymph nodes, these are worse prognosis. So it all depends on what is how the character of the entire progression that we get in front of us. Then we decide about our imaging. But as I said, most of the times it is EUA with PET, and based on this, we start our treatment. Secondly, when there are a lot of big para-aortic lymph nodes, at least in our tumor board, we find that most of them will have a supraclavicular also. These patients go for palliative chemotherapy. We don't give them curative therapy. Second, I'll talk about the management later. So basically, this is how everybody needs to think about CA cervix and, evaluate that, get your EUA, be more clinical, take biopsies first, don't do imaging first, prove that there is a cancer, then do a staging, have an idea of doing PR examination, keep good Lugol's iodine in your OPD. If you find CA cervix, if you want to see vaginal involvement, apply Lugol's iodine properly to the vagina. A good PR and a parametrial involvement. Believe me, I trust my fingers more than the MRI notation of whether parametrium is involved, because we have seen how parametrium gets involved, how inflamed parametriums are, how involved parametriums are, and how to reach up to the lateral pelvic wall. In PR examination, we have even been able to find out an obturator lymph node also. So, I mean, a good clinical examination, whether it is any aspect of gynecology, I will say it is completely clinician based. Obstetrics is radiology based, because everything, you don't have to do anything. Everything sonography only tells you about the baby. But in gynecology, you have to do everything for the patient. So I think focus more on clinical examination and see to it that you give correct imaging so that the decisions are made. Because just yesterday I had one of my gynecologists had a USG said fibroid, then they said MRI, then MRI said possibility of a sarcoma, then they did PET CT. I mean, how much will you do? This is not required. I mean, the patient will get exhausted. Patient was crying, sir, itna karte karte hi hamara dam nikal gaya. So what treatment they will take? So very strictly limit your investigations and be very clear which investigation you want to do. And for me, I do only for medical legal purpose, so that if other oncologists ask me whether you have done or not, that I'll say yes, I have done. But my decisions are based on my clinical judgment only. So that is the difference that we need to have while working in cancers. We have already had this staging. I'm not, the new things have also been told. I think this 3C1 and 3C2, which has come up in this lymph nodes, is a big headache, because over a period of time, over my experience, I find that PET confuses you more rather than tells you something. Because a PET does not tell you about inflamed nodes, reactive nodes, and a metastatic nodes very clearly. And then what happens is, if they say that it is whatever pelvic lymph node seems to be positive, unless the SUV max is very high and it is very clear that it is involved. But then what the medical or the radiation oncologist expects is you need to take biopsies from this lymph node to prove this lymph node's metastasis. I mean, this is too much of invading the patient. And that is why sometimes I think, remember one thing, I know one thing, and the head of department also knows, PET is never and will never be the primary screening for any gynecological malignancies. So please do not subject your patients to PET as a primary investigation. Not required, it is over. After that, you also have to understand that PET tries to overdiagnose lesions also. So you need to know the SUV max, the size of the tumor, and what is the size and what is the SUV max. So that correlation has to be made to actually understand whether it is a positive FDG uptake. And then you have to talk to the PET consultant also. Then only you can make an idea of, what is actually happening with the patient. Otherwise, most of them are getting over-reported, is a clear opinion of our tumor board also. I'm not going into too many pathology classifications, because as gynecologists, you will be seeing most of the squamous cell carcinomas only. We have seen sarcomas of cervix and metastatic CA cervix also. So what determines the prognosis is, according to me, the depth of stromal invasions, the parametrial involvement. If a surgery is being done, then the status of surgical margin and LVSI. So these are the most important prognostic factors for me. There is nothing called as in situ carcinoma, so I'm not going to discuss now. 1A1. Now we had put this management of stage 1A1 CA cervix and in a DNB examination, and all students expectedly answered wrong. All of them. Nicely writing about Wertheim's hysterectomy in stage 1A1, all have got 0 marks, and they deserve it. Why? Because 1A1 is not understood to be micro-invasive disease. That is one. And 1A1 and 1A2 are diagnosis of colposcopy-based lead specimen only, not of simple biopsy. That means if you have a patient with a screening with an HSIL or an ASCH, then you do colposcopy. On colposcopy, you find a high-grade lesion. You biopsy that high-grade lesion. The biopsy comes out as a high-grade or a possible microinvasion. Then you do a leads, and on that lead specimen, the diagnosis of 1A1 should come. 1A1 is not an acceptable, and 1A2 is not an acceptable diagnosis on just a biopsy. It has to be on lead specimen. And once that is confirmed, then only you can go ahead. And that is why, if as gynecologists, you do stringent colposcopies for all your patients, that is what we are doing. And that is why we are picking up many women in 1A1, 1A2. And as already earlier, I think somebody has spoken, 1A1, the treatment is either do a cone. If you have done a leads, you can do an extended leads, or you can do a cone. I mean, whatever you do, you can even save the uterus of that patient. 1A1 and 1A1, all of them can fit into your fertility sparing, provided you do not have LVSI positive or a lymph node positive. And even 1A2 can go for your fertility sparing, like trachelectomy, and you can preserve uterus. So what happens is, in microinvasion, and remember one thing, now with those NCCN guidelines and everything coming off, CA cervix stage 1 is monotherapy. So you cannot have 1A1 or 1A or 1B undergoing surgery and then undergoing chemo and radiation also. So it is either surgery alone or chemo radiation. So that is the crux of current management of CA cervix, monotherapy. So if you want to give monotherapy, you diagnose, and if you want to do surgeries, then you diagnose more in stage 1. Then only it will be possible for you. So in my hospital, 1A1, 1A2, 1B1 are the ones that I do surgery, and very selected cases, and that too if the tumor board allows, then 1B2 will be for surgery. So if because when I walk into conferences, अरे मैंने तो 50 CA cervix की है, I think that is all wrong, because ये 50 tumor board में आते हैं ना, तो 5 भी नहीं कर पाते. So we have to respect what the medical oncologist and radiation oncologist also decides as far as CA cervix is concerned. And most important, we look at oncologic outcomes. We don't look on how great surgery you have done. We look at oncologic outcomes. So oncologic outcomes are based on which stage, what treatment, and how correctly it is being done. Secondly, it is completely unacceptable if after a hysterectomy a CA cervix is found, because if that is the issue, that means a per speculum examination was not done either prior in the OPD basis also, even prior to starting the surgery also. So please avoid situations where you have done a hysterectomy and then a CA cervix has come. This is again unacceptable. So 1A1, 1A2 will probably go for a hysterectomy. 1A2 will probably go to type B hysterectomy. When we talk of radical hysterectomy, basically for 1B1, 1A2 and selected cases of 1B2, then we have all these issues. We need to understand one thing. In fact, this would many medical and the radiation oncologists in the audience will concur with me. There is no role of laparoscopy in CA cervix. How much ever big everybody talks, after the LACC trial, it is clear, even I have stopped doing, even my colleagues have stopped doing. So please do not do laparoscopy for CA cervix, because if there is a problem, nobody is going to save you from any medical legal issues, because it is very clear that CA cervix currently, whatever people say and do, however that trial was is shown to be wrong or malified or something, it is still the current treatment norm is CA cervix, radical hysterectomy is always open, preferably a vertical incision. So 1A2, as I said, we do a modified hysterectomy. We are doing pelvic lymph node with it. We are not doing para-aortic. So what we do is, when we open, the first thing we do is we go to the para-aortic and pelvic area. We palpate all the nodes. If any of the lymph node is found to be positive, which is not picked up by the PET, it doesn't mean that a PET has done, that means everything is negative, you straight away start the hysterectomy. No. You open the abdomen, first go to the para-aortic and pelvic area, see if there are any palpable, not visible, palpable lymph nodes. If you find them, suppose, pick them up, send for frozen. If it is positive, close the abdomen and send the patient back. Because as it becomes advanced stage, that means 3C1 or 3C2 based on pelvic or para-aortic positive, close the abdomen, talk to the relative and says that she goes straight away for concurrent CTRT. Women not fit for surgery, I think most of the times we have radiation to our rescue, palliative chemotherapy. So as such, chemotherapy does not have much more role rather than just being a concurrent. That means radiosensitizing agent as far as CA cervix is concerned. As far as tracheectomy, I have just done 2 tracheectomies and both have conceived and delivered. But as I said, as we are picking up more and more 1A1, 1A2, probably the incidence of doing tracheectomy. Now again, tracheectomy, before doing a tracheectomy, the PET CT has to make me clear that there are no lymph nodes or FDG avid lymph nodes. Secondly, when I do a tracheectomy, to be double cautious, we put in a laparoscope from above and check the pelvic and para-aortic area to see if there is any enlarged lymph nodes. Okay, so that is to double check while doing a radical tracheectomy, because I said I need to give a good oncologic outcome to the patient. The radical hysterectomy, believe me, once you have done a radical hysterectomy, you will understand the pelvis far more better. Whether you're doing, most of them are now nerve sparing, but the pelvic anatomy cannot be much better than in any other surgeries, rather when you do a proper radical hysterectomy. And it's an old slide. I'm not doing sampling of para-aortic. We are doing a complete para-aortic lymphadenectomy also. Now, a lot of discussion about post-lymphadenectomy issues with the patient. We have no issues till now, till date. Why? Because all the patient gets a very good physiotherapy support. For me, every oncologic surgery is equal to physiotherapy. Not a single patient, and these physiotherapists go at home also. So the limb edema and all those things, or even in CA breast, the limb edemas we don't see because we started actively from day one. 2A1, 2A2. Just now we had on Thursday we had this patient. Patient was CA cervix, biopsy proven. The surgical oncologist in somewhere in Pune was called to do the surgery. They opened the patient, then they found that it was inoperable. It was probably 2A2. They closed the abdomen. So idea is, as an oncologist, if I've been called to say, come, I've seen the patient and I'm not doing that, I will evaluate the patient from my point of view, because, taking up in the OT, giving general anesthesia, opening and then realizing it is high stage, it is inoperable and closing, it's a nightmare to the patient psych, the relative psych, and believe me, these patients don't even go for radiation and chemo. So if you're called for doing something, it is better that you evaluate the patient and then take a decision whether to operate or not. I think the previous speaker said, initially we used to do NACT in CA cervix, especially for this, because previously we just had 1B2, now we have 1B2, 1B3. So 1B3 as it is straight away goes for RTCT. So 1B2 selected cases, we used to do NACTs, but after Tata Hospital presented the paper in ESGO, even that and showed there is no role of NACT in CA cervix, even that is being stopped. So even 1B, that's why I said it's only selected 1B2 in our tumor board. If it is passed, then only we go ahead with surgery. Otherwise, even 1B2, 1B3 goes for concurrent chemo radiation. I think after surgery, yes, is after surgery. Now, with the stringent criteria that we have at 1A1, 1A2 and 1B1, only thing that is not in our control is the stromal invasion, which we as it is cannot assess by any of the imaging previously. LVSI, which again we cannot assess. So these are the only 2 indications where after surgery in stage 1, we have to send the patients for adjuvant radiation and not chemo radiation. They get only adjuvant radiation. We are not giving, in case there is, I think there are, in last year only 2 patients required adjuvant radiation. We are not giving adjuvant concurrent CTRT. We are giving only adjuvant RT, which is complete external and brachytherapy. Let me talk about 4A. We have had 5 exentrations done. Now, selected case of 4A, wherein you have the CA cervix directly going up into the bladder or into the rectum, sparing the parametrium, sparing the vagina, negative lymph nodes in the pelvis and para-aortic area and the supraclavicular. These cases We discuss in the tumor board, and we have done 5 exentration. Of course, most of the other patients, they go for palliative chemotherapy, but selected cases, and in all these patients, if it is a bladder, a cystoscopy is done, a cystoscopy guided biopsy is done. If it is a rectum, colonoscopy is done, colonoscopy guided biopsies are done, cancers approved. So 4A is only and only when the mucosa is breached. If it is inside the mucosa, if the mucosa is not, if the tumor has not breached the mucosa and it is not seen on colonoscopy or cystoscopy, we don't call it as 4A. So 4A, there is a little window, a very small window, and of course this has to be done by tumor board. It cannot be done by individual oncologist also. In selected cases, we are doing exentrations. Otherwise, most of these patients go in for a palliative chemotherapy. So that is what I was talking about, surgical exentration. So yes, if you ask me, there is a little difference. People from, women from what we see is a little higher socioeconomic conditions. What we see is the CA cervix going like this, right from the cervix into the nodes or into the bladder or into the rectum. It is very difficult. It is very rare to see in these patients going into parametrium. While if you see the women in low socioeconomic group, they properly follow the natural history of the spread of CA cervix. So that is a little difference that we have found in at least our private setup. 4B, again, palliation. Most of these disease-free survival has been discussed. Now this is the one which I was talking. After simple hysterectomy, if we find 1 month, means that we should not have a CA cervix diagnosed after a hysterectomy. It is very, very bad. It leads very bad on the practicing gynecologist also. Secondly, if it is found, it has to be a repeat surgery. It is a protocol in our tumor board that if a gynecologist has operated a case and if it is a cancer, we have to do it again, because 100% the gynecologist will be an unstaged patient. So the tumor board rule in our hospital is if it has been operated and then you have a cancer, immediate restage. Even if the sutures are not removed, we immediately take the patient for surgery, because as close to the previous surgery you take, it is a little difficult because there is a lot of reactionary MR, but that's fine. We need to give a patient a good oncologic outcome that will affect the OS, that is the overall survival. So if the hysterectomy is done, suppose if I come to know that on a Monday a hysterectomy done, Thursday you have a report of CA cervix, Friday the patient gets operated, and we do complete surgery where we remove the parametrium, vagina, nodes, everything. And then the final histopathology report goes, and then it comes for discussion whether an adjuvant is required or not based on the histopathology report. Where it is not possible, or if the patient has come too late, means diagnosed, done on Monday and come after 1.5 months, then of course she undergoes a PET and then they directly go for concurrent CTRT or chemotherapy based on what it is. But please remember, it reflects very bad on the gynecologist that if a CA cervix, where cervix can be so easily be seen clinically, is identified after a simple hysterectomy. I'm not going to talk of recurrent disease, as most of the audience, barring 1 or 2, most of the audience is gynecologist. Carcinoma, this would be interesting. We have managed, I think, 4 cases, and they were found to have CA cervix with the pregnancy. So that this is the place where the role of medical oncologist comes. So after 24 weeks, we have given them single agent chemotherapy agent till 32 weeks, and those who out of them 2 went into preterm labor at 28 or 30 weeks, and 2 went up beyond 34 weeks. So that can be done. Conization, well, can be done if it is early, but you have to explain the patient that there will be a risk of preterm labor. So although incidence is very less now, in fact, now also we have got a reference from Bombay Hospital, Mumbai. A patient has come. She is 29 weeks, and I think she's 1B2 or 1B3. And they have started her on chemotherapy. We have been continuing the chemotherapy. She has reached 29 weeks. So we are getting those cases in pregnancy also. I'm not going, that's the intracavitary brachytherapy suit. I'm not going to tell. We know most of the classification. The current is the Cuerlo and Moro classification. I'm not sure whether it is really visible, but what we are following is type A, B1, B2, C1, C2, and D1, D2. That's the, you need not get more confused. The more and more you go lateral to the ureters, then you have those B2, C1, C2, C3 going on. Okay. What we do is type C1, C2, which was the earlier type 3. So just giving you, as I said, the rule will be whatever, even if it is 1A1, 1A2, 1B1, selected 1B2, open the abdomen, first go into the paraaortic and pelvic area, see if there are any palpable lymph nodes. If so, then send them for frozen. If frozen is negative, proceed with the Verdines. If the frozen is positive, close the abdomen. Now, as far as closing the abdomen, when you're proceeding with it, it is very clear, stay as much lateral. Do complete ureteric dissection, right up to its entry into the bladder, remove the entire parametrial tissue. The crux of a radical hysterectomy is it's not just lymph nodes, it is removing parametrium and vagina, because majority of the recurrences occur in this. And what we are doing is, our tumor board expects me to remove at least 2.5 to 3 centimeter of vagina. In one of the patients, we had abdominally done total vaginectomy, because we found there was some suspicion, which was not picked up by MRI, by PET or EUA, iodine also. We found that there was something in the vagina. So we removed the entire vagina. That patient is doing fine. So I think because CA cervix comes back very fast. So it is always better that you have good appetite for dissection and do a lot of dissection so that you can provide patients a good OS. So try to be as lateral, remove complete parametrium on both the sides, and remove as much of vagina as possible. And of course, doing lymph node dissection is as it is a part and parcel of our distinct. So nothing great in it, but parametrium should be removed completely is the crux. Vagina should be removed. They are saying 1 centimeter, 1.5 centimeter. We are removing 2.5 centimeter for it. So I'm not going into too much details of these pictures. I think most of you are aware about it. And yes, the uterosacrals, most important is that uterosacrals, we don't take the uterosacrals like this. We go onto the rectum. So since the pararectal space is dissected, the uterosacral clamp goes exactly where the uterosacrals are going into the sacrum. So you have to dissect the sacral plexus, take the nerves away. And that is why they talk of nerve sparing and non-nerve sparing. So here we have to do nerve sparing. You push the nerves ahead and then put your clamp on the uterosacral close to the rectum and lift it from there. Only from behind, when you lift, when the uterosacrals are taken up, then only the uterus gets lifted for you to get adequate vagina. So that is the principle of uterosacral dissections. And of course, please remember, it is not just doing surgeries or not just giving chemo or not just giving radio. You need to understand that post-radical surgery, what are the important things that you need to do to the patient to get them out of the surgery. Why? Because if at all these patients require an adjuvant RT or an adjuvant CT-RT, they should be fit within 4 weeks from the day of surgery. So you need to make those patients, whether it is a cervix or an endometrium or the ovary, if they are going to require a adjuvant, you have to ensure that you have to make them fit by 4 weeks and see to it that they get their adjuvant on time. So understanding the post-op care is also a part of this, because just doing surgery is not enough. Post-chemo radiation, you need to have, if you're doing a CA treatment, you should be equipped in dealing with all post-op issues, post-chemo radio issue. You should have a palliative setup, and you should also be prepared for end-of-life support. Only if all these things are there, then you can do justice to your patient and justice to the patient's family. So we are focusing on fertility sparing, but as I said, very strictly. Again, fertility sparing decision is not a decision of a single oncologist. It's a tumor board decision that, yes, okay, we can clear this patient for a fertility sparing. I've spoken about nerve sparing surgeries and avoiding dual method of treatment in stage 1 cancer cervix. We need to adopt to single line. That is why start doing more colposcopies, start doing more screenings. You will get measured. Let us change the textbook lines that majority of them are in stage 3, stage 4. We don't want those false smelling discharge. We want 1A1, 1A2, 1B1, which as you had seen earlier, 95% of survival. Only surgery is more than enough. No need for adjuvant. So start doing that more. As far as cervix is concerned, there is no role of laparoscopy robotics. If it is done, it is wrong. No tumor board in this country or anywhere in the world will accept. And yes, there is a role for robotic and in fact robotics has now taken over laparoscopy in CA endometrium. Again, for ovarian masses, there is no role of laparoscopy and robotics. So it is only CA endometrium where laparoscopy and robotics can really work and give you good results and good overall survivals. So we are a part of a National Cancer Grid initiative of Tata Hospital. There are about 30 centers, and we are following the tumor board protocol of Tata Memorial Hospital. So if every case is discussed in our hospital, if we do not agree on ourselves as to the line of management, we present this case through a web link to the Tata Hospital tumor board, and probably we get all aspects of the treatment. And as I said, we are giving all, it's not just cancer surgeries, it is cancer, radiation, chemo, palliation, end of life support, radiology, oncopathology, everything is available in the one. So CA cervix has always been a wet road ahead. We have a lot to do. And as per the WHO, we are talking of elimination of CA cervix by 2030. Which means that 90% women should be screened, vaccinated, 70% should be screened, and 90% should have been treated in pre-cancers. That is CIN1, CIN2, CIN3, 90% of the patients should be treated. So unless and until gynecologist gears up, starts really taking, and in fact, believe me, in my hospital, none of my students like to do obstetrics because they see me. Most of the students are with me. They are not going to the obstetricians. So I guess, yes, where you have controlled the mat mortality and got it down, it is now also important that we have every 8 minutes, one woman dying of cancer cervix. We need to get it down by, if there are postgraduate students in it, there is a good chance, start taking subjects which were not taken earlier, start coming into oncology. We also have an MCH gynae oncology. So, this is also an interesting area. Thank you for the opportunity. I'm open to questions.
Any questions from the audience?
Sir, any role of laparoscopic lymph node sampling?
Sir, is there any role of lymph node sampling laparoscopically?
No, that word sampling is completely out. There are no samples. Either you do a lymphadenectomy or don't. There is nothing called sampling. So as far as CA cervix is concerned, as I said, for 1A1, you can omit lymph node, but 1A2 and upwards, it is complete lymphadenectomy. In 1A2, you may omit a para-aortic lymphadenectomy, but 1B1, 1B2, it is complete pelvic lymphadenectomy, both pelvic and para-aortic. There is no role of sampling.
Nikhil, it was really a very nice presentation. And just one query about this incision thing. Nowadays, with fan and steel also, little extended fan and steel, we are able to do the radical hysterectomy quite successfully. But any particular say on that why you were insisting on the vertical incision itself?
Because I'm not very convinced on how you can achieve a complete para-aortic lymphadenectomy in a fan and steel incision. Because even with vertical incisions, we have to put the entire intestine behind, reach the D2 segment of duodenum. Okay, even with vertical incisions, many a time we struggle. So if para-aortic lymph node has to be done, it is very, very difficult with extended transverse incision. Even coil joints or incision may not work. And most of these patients in the Indian women, where you have those obese tummy, I guess vertical incision works better in getting, because idea is you need to give good sample, good adequate tissue to the pathologist. It is not, it has nothing to do with, in cancers, we do not believe in cosmesis. It is very clear. So what we believe is giving R0 as much as possible. Because the more you give R0 to the patient, your medical oncologist will be happy, your radiation oncologist will be happy, and this will affect OS.
Okay, yeah. And you mentioned about that CA cervix with pregnancy, and you mentioned about the chemotherapy in the first trimester. So, can you elaborate a little more on that? Because
No, not in the first trimester, after 24 weeks.
Achha, okay, great.
So after 24 weeks, once all your malformation and all those things have been done, your fetus is fine. At that time, we start the chemotherapy.
Yes, yeah. Okay.
And it is being, and generally it is given as weekly, because again, we cannot give those 21 days dose. It is always given weekly.
Yes.
For 18 weeks.
Correct, yeah, thank you.
Doctor, it was a very nice talk, and I'm very happy that you stressed on first speculum examination, which is being almost being forgotten in gynec practice. So it is very necessary to do a speculum examination, which you have very nicely stressed upon. That if patient comes, speculum examination should not be omitted, because many a times it happens that patient goes for sonography, transvaginal sonography, but speculum examination is exempted. So doing a speculum examination is very, very important, which you have very nicely stressed. Thank you.
Thank you, madam. No, I think this has to go to every medical colleges also. Unless a student doesn't answer an MA per speculum examination question, they should not be given MSMD degrees.
Any more questions? Sir, since you're presenting online, please accept a e-trophy from all of us.
No, it's fine. Thank you. Thank you for giving me the opportunity to talk to all of you.
Thank you so
I
much, sir.
think long time after the colposcopy workshop, I think I'm
Almost
meeting
3 years,
SOGS.
sir.
I'm meeting the SOGS.
Yes.
Thank you, Anjali madam. Thank you, Archana madam. Thank you, SOGS.
Thank you so much, sir. I now request Jamma madam to please felicitate the chairpersons for today evening. Thank you, everyone. We are extremely happy to announce that our very own member, Dr. Praveen Khare sir, has received a Special Appreciation Award at the Family Planning Summit at New Delhi from the auspicious hands of Dr. Bharati Pawar, the Health Minister of Maharashtra, for performing the highest number of laparoscopic tubal ligations in Maharashtra, more than 6,000 cases. I request Sardesai madam to please felicitate him on behalf of SOGS. Thank you, ma'am. Thank you, everyone. There are a few important announcements. Our labor conference has been shifted to 12th and 13th of November. So we request all the members to be a part of this various committees for the upcoming conference. Another one that we are planning to arrange a cruise from Mumbai, Goa, Mumbai for 3 days at the end of November with Cordiala Cruises, and we are still in the negotiation stages. Those who are interested, kindly do join the group which we will make on WhatsApp so that we can bargain better with them. Finally, at the end of the CME, I would like to extend our vote of thanks to our esteemed faculty, Dr. Vaibhav Meru, Dr. Sarita Mittal ma'am, Dr. Vipul Doshi sir, and Dr. Nikhil Parvate sir. Our chairpersons, Dr. Vrinda Chaudhary madam and Dr. Praveen Khare, and Dr. Sailesh Patne from Pathkind Labs. Our delegates, Samendra, Mohan, and Ambuj for Sarovar Settings, and Ivare. We invite all of you for a delicious dinner. Thank you.